Good afternoon and welcome to this session entitled Back Pain Basics When Back Pain Keeps Coming Back, the Diagnostic Approach to Back Pain. My name is Dr. Alan Kerpus. I'm from the section of Rheumatology of the Ilocos Training and Regional Medical Center. The objectives of this lecture are to discuss the diagnostic approach to back pain and to discuss the different arthritis and systemic conditions that can cause back pain and illustrate this by presenting three uncommon but potentially permanently disabling and possibly fatal causes of low back pain that need immediate recognition, treatment, and or referral. The following are my disclosures. So why are we talking about this? It's because back pain is very common. It affects 84% of adults at some point in their lives. In fact, the pandemic caused by COVID-19 has caused another pandemic of musculoskeletal conditions, which includes back pain, because of the abrupt shift to social distancing, which increased remote work, resulting prolonged sitting behaviors and computer use. In a survey done at the UK, 4 out of 5 developed musculoskeletal pain due to work from home status, with about a third to half of these patients receiving no equipment, support, or advice to address their back pain. In fact, pre-pandemic, we were already struggling with treating low back pain. It affects 65 to 80% of individuals during their entire lifetime. It is the most prevalent chronic pain syndrome and is the second most frequent reason for visits at the clinic. The good news is that pain and function improve substantially within 1 month, and more than 90% of patients are better at 8 weeks. However, these patients may still be susceptible to future brief relapses, with only about 7 to 10% progressing into chronic low back pain. The diagnosis of low back pain can be a pain in the neck or a back-breaking activity. It's classified by duration of symptoms, with those presenting less than 4 weeks labeled as acute, and those having symptoms lasting more than or equal to 12 weeks labeled as chronic. For a lot of these patients, however, the episodes of low back pain are limited, self-limited, or benign, and rarely, in about 5 to 10% of patients, it can be a harbinger of serious medical conditions. The risk factors are divided into 3. You have your physical factors, which includes your mechanical loading or obesity. You have your pregnancy, arthritis, osteoporosis. You have your bad posture and physically strenuous or repetitive work. You have the individual factors, which cannot be modified because it's a function of our genetics. And then you have your psychosocial or organizational factors, which relate to the social issues around us. And the literature shows that all this independently lead to back pain. So what's the common thread among all these risk factors? Well, the common thread is the way that the body and the mind in particular interprets the information. So we get the information about the world from what we hear, from what we see and what we feel, from the emotions that we have. And these are all fed into the brain for processing. The brain processes this and recruits muscles in our torso. And these muscles are what really load the spine. So what happens is that for patients who have high levels of stress, they have more of what we call your co-contraction. And co-contraction is what happens when the muscles of the torso are engaged in a tug of war with each other, which greatly increases the stress as opposed to what it really takes to perform the tasks. And that's how these increased loads occur, and that's how it's tied to the brain. This is the algorithm for the diagnosis of back pain. And if you take a look, it starts with the taking of a focused or good history and physical examination in order to categorize patients into non-specific or mechanical low back pain, patients with neurologic signs and symptoms, and patients with red flags that indicate the risk of systemic disease such as infection, malignancy, spondyloarthritis, or vertebral compression fracture. Those patients with non-specific mechanical back pain can be conservatized, while those patients with neurologic signs and symptoms will probably need urgent imaging such as an MRI or urgent surgical consultation, especially if they are in a state of spinal emergency such as a cauda equina syndrome or the presence of serious or progressive neurologic deficits. Those with red flags will likely require also plain radiography, ESR, or MRI to confirm the presence of systemic disease. It is important to note that 90 to 95% of low back pain is mechanical in nature and will be self-limited. And the key here in the initial and subsequent evaluation is to find the 5 to 10% that can be permanently disabling or fatal. And that's where the red flags come in. The red flags are clues to the presence of underlying systemic diseases. They identify the small proportion of patients who may have neural compression or underlying systemic disease as a cause of back pain, as these patients require early testing or treatment. It is also important to look for any social or psychological distress, such as job dissatisfaction, pursuit of disability compensation, and depression that may amplify or prolong the pain. The differential diagnosis of back pain is divided into mechanical low back pain, non-mechanical spine disease, and visceral disease. And for mechanical back pain, usually the prototype disease would be your degenerative disc disease or those with disc herniations. These patients can present with non-specific symptoms and will have radiologic abnormalities on plain radiographs as well as MRIs. Patients with disc herniation can have sciatic pain and have neurologic manifestations such as lower extremity sensory loss, a positive straight leg raise test, and impaired ankle or patella reflex. Patients with spinal stenosis will have severe leg pain presenting as pseudoclaudication or pain on prolonged ambulation or standing. And this pain actually disappears when the patient is seated or when leaning forward. The patient will walk with a wide-based gait and there's thigh pain after 30 seconds of lumbar extension. This is usually seen in patients who are more than 50 years old. Ankylosing spondylitis is very close to my heart as a rheumatologist, as it is usually missed as a cause of back pain. These patients will usually be less than 40 years old, will have decreased spinal range of motion, especially later in the course of the disease. And the key in the history here is that the back pain improves with exercise and worsens with rest or immobilization, in contrast to your mechanical back pain, which worsens with activity. The onset is gradual, and usually the pain lasts for more than 3 months. And there's very severe morning stiffness. For infections such as osteomyelitis, spinal abscess, and epidural abscesses, usually the patients will have a history of recent infection or history of intravenous drug use. Some of these patients may be undergoing chemotherapy or hemodialysis, and they will present with fever and localized tenderness. And when left untreated, it can cause cord compression. Cancer in the spine or surrounding structures will usually present with a history of weight loss or other cancer symptoms and will have a known cancer diagnosis. Usually, this comes from the prostate, breast, and lung cancer, and when left untreated, can also cause cord compression. Intra-abdominal visceral disease can cause back pain depending on the affected viscera, and this can be secondary to gastrointestinal disease such as your peptic ulcer, pancreatitis, or cholecystitis. It can be genitourinary in origin, such as your nephrolithiasis, pyelonephritis, prostatitis, or pelvic infections or tumors. It can also be vascular, such as your aortic aneurysm or aortic dissection. Then we have metabolic bone disease, such as your postmenopausal osteoporosis with osteoporotic compression fractures. These patients will have a history of trauma sometimes or prolonged corticosteroid use. Some of these patients may have underlying autoimmune disease such as rheumatoid arthritis or psoriatic arthritis or even lupus. There's localized tenderness if the vertebra is fractured, and the best example, as mentioned, is osteoporosis with compression fracture. Herpes zoster can also cause back pain, and usually there's a unilateral dermatomal vesicular rash, usually seen in elderly or immunocompromised patients. And finally, psychosocial distress are seen to manifest with back pain without a clear anatomical or clinical pattern. And these patients are at high risk for delayed recovery, chronic pain, and poor functional outcomes. So when do we order imaging? We have to be careful not to subject our patients to vomit. So what's vomit? It's victims of medical imaging technology. You have to take note that radiographic exams are usually of limited use unless the history or PE suggests a specific underlying cause. There's a weak association between imaging abnormalities and symptoms. And by imaging a patient, you're just giving him a false, sometimes a false idea of what his condition really is. Because in up to 85%, one cannot make a precise pathoanatomic diagnosis with identification of the pain generator. In fact, in this systematic literature review, they found out that disc herniation is prevalent in pain-free individuals. You see here that patients who are as young as 20 to 30 years old or 40 years old already have at least 37% of disc degeneration. And they can also present with other manifestations of degenerative spine findings. However, this study proves that the demonstration of anatomical abnormality should not automatically lead the clinician to assume that it is the cause of pain. Earlier use of imaging for low back pain without associated symptoms is not associated with improved outcomes and will only increase medical costs and the use of invasive procedures. Therefore, each imaging is not required unless the symptoms are persistent beyond 6 to 8 weeks. Because neither an MRI nor a plain radiograph taken early in the course of back pain can improve the clinical outcome or predict recovery course. This is a guideline from the ACP and the APS showing that imaging is useful as the pretest probability of underlying serious disease requiring surgical or other intervention increases. It says here that we are only required to do immediate imaging if there are major risk factors for cancer, infection, or progressive neurologic deficits, and that we can defer imaging even for patients with signs of ankylosing spondylitis or vertebral compression fracture, or those with weaker risk factors for cancer, and that we do not need to do imaging if the patient has alleviated or resolved back pain after 1 month trial of therapy. So what about the other diagnostic tests? Other tests are not indicated in most patients with low back pain. The ESR may be helpful in ruling out systemic problems. The EMG-NCV is useful if we're thinking of myelopathy, radiculopathy, neuropathy, and myopathy. However, the EMG-NCV should not be tested if the duration of symptoms is less than 4 weeks because it will be unreliable. So let's proceed to our cases. A 66-year-old man was referred for left upper quadrant pain and mid to low back pain. The pain started about 3 months prior to referral as a pain that awakens him at night, and the pain was described as shooting or stabbing. He also experienced pleuritic chest pain and was under the care of an internist who treated him for diabetes with the following medications. The latest fasting blood sugar was 230. He had numbness around the middle back and also on the left calf area for about 5 months. He had no fever, anorexia, weight loss, or bladder or bowel issues. He was started with pregabalin, vitamin B complex, and tramadol, but had minimal relief. On physical exam, vital signs are normal. The BMI is 30. The gait is normal. The other physical examination findings are normal. Chest X-ray showed a right hilar mass. The ESR was mildly elevated. Sputum AFB was negative. The CBC was showed mild anemia and mild leukocytosis. So which of the following is the most appropriate diagnostic test to perform in this patient? The answer here would be a thoracic MRI and or a chest CT scan. So a thoracic MRI and a chest CT was done, and the MRI showed T7 to T8 disc abnormality brightness on T2 weighted imaging with associated subchondral irregularities of the opposing end plates, which extends posteriorly to the epidural region more to the left, causing spinal canal stenosis and compression of the adjacent thoracic cord. Focal hyperintense signal on T2 weighted imaging are seen relating to edema, and there's bilateral neural foraminal narrowing, mild on the right and severe on the left, possibly compressing the left exiting nerve root. Pre and paravertebral mass is seen from T6 down to T9, and there's mild compression at T7 and T8 with diffuse marrow edema. On chest CT, the findings in the T7 to T8 regions may relate to spondylodiscitis with mild indentation of the ventral thecal sac and probable paravertebral abscess formations. So an initial diagnosis of PTB with POS was made. The patient was then referred to spine surgery, but opted to go to Manila where he underwent spinal surgery eventually. Samples taken from the lesion came out negative for TB. So the final diagnosis came back as bacterial paravertebral abscess, status post-debridement, and decompression with spinal fusion. So the red flags in this case are uncontrolled diabetes, nocturnal pain, age more than 50, and an ESR elevation. And sometimes DM can cause immunocompromise, which may explain the only slightly elevated ESR as well as the absence of fever and indolent presentation, mimicking TB despite having a bacterial abscess. Always ask in the history potential causes of immunocompromised states, such as your RA, SLE, HIV, chemotherapy, and the use of steroids. For case 2, an 80-year-old male who was previously diagnosed with prostate cancer in 2010 underwent CTERP and received injections as chemotherapy under his attending doctor. He did not have any follow-up after that because he was already feeling well, and the patient did not have any lower urinary tract symptoms since 2010. So he started to have persistent progressive low back pain for 2 months, which was not alleviated by rest and was worse at night. There is minimal relief with paracetamol and NSAIDs. There was anorexia and weight loss, and recently, patient had acute weakness of both lower extremities. There was also urinary retention with overflow incontinence, and the laboratory studies showed an elevated ESR with anemia, leukopenia, and an elevated PSA. So which of the following is the most appropriate diagnostic test to perform next in this patient? The answer here would be a bone scintigraphy scan. So x-rays were done showing osteoblastic metastasis, and a bone scintigraphy scan was done showing increased tracer activity in almost all parts of the bone. And there was an osteolytic process in the proximal shaft of the left humerus, in the T4 to T5 and T11, and the lumbar vertebra. So the red flags in this patient are the history of malignancy, nocturnal pain, weight loss, anorexia, and elevated ESR, as well as bladder dysfunction. Note that prostate cancer is a common cause of vertebral metastases in males, and the other malignancies such as your breast, lung, thyroid, and kidney can cause metastasis in 80% of cases and multiple myeloma in 60% of cases. So the important thing to note here is that you always have to ask for history of malignancy in patients with chronic low back pain, especially in male patients with prostate problems. So you need to ask because these patients will not volunteer the history of malignancy as it might have occurred somewhere in the distant past, and the patient may not be able to remember mentioning it or correlate it with their current illness. Sometimes it's not very clear because the pain will only be mild and there will be no constitutional symptoms. So the diagnosis here is vertebral metastasis from prostate cancer. The patient improved with zoledronic acid weekly infusions. The third case is a 27-year-old male with chronic back pain and knee pain. He noted that the onset of his back pain came on gradually when he was in college, where he was working as a barista, but his pain progressively limited his ability to bend over while preparing drinks for his clients. He saw a doctor at that time. An x-ray was done of the spine and the hips. X-ray was normal. Patient was diagnosed with chronic back strain. He was prescribed with mefenamic acid, which he took 1 to 2 tablets when the pain was particularly bad. However, the patient noted the discomfort was worse when he woke up in the morning and was associated with stiffness that lasted up to 2 hours after getting out of bed. The pain and stiffness improved as the day went by, and he participated in his normal activities. He also had this pain on his heel on the first step, which improves with ambulation and recurs after a period of rest. By the age of 24, patient had pain on the right hip, left knee, and right foot, and at this time he stopped his work due to the pain. He denies history of any inflammatory eye disease, bloody diarrhea, or any signs of inflammatory bowel disease or psoriasis. He had repeated consults with different doctors and specialists who gave him different drugs, ranging from NSAIDs, colchicine, allopurinol, as well as physical therapy. So on physical examination of the clinic, the patient had diminished internal rotation of the right hip, and his left knee was warm and swollen, and he had tenderness at the plantar fascial insertion. The anterior spinal flexion testing was 3.5 centimeter, lateral spine mobility was 15 centimeter, occiput to wall distance was 0 centimeter, and chest expansion was 3 centimeter, which were all normal. So for this patient, what is the most appropriate diagnostic test to perform? A lot of you would probably say LSV X-ray, and that's where the pitfalls in imaging happen in these types of cases. The correct answer here would be to do a pelvic X-ray. So examination showed an elevated CRP and ESR. This patient was also tested for HLA-B27, which turned out to be positive. And on X-rays of the AP pelvis or the sacroiliac joint, it showed sclerosis and erosions at both the sacroiliac joints compatible with grade 3 sacroiliitis, osteophyte formation in the right hip. The X-rays of the lumbar and cervical spine showed joint space narrowing. So you see sometimes the X-rays of the spine can be normal, but the X-rays of the sacroiliac joint will show you the pathology. So this patient was diagnosed as axial spondyloarthritis, with this patient having reached later stage disease diagnosable as ankylosing spondylitis. And the doctor who saw this patient initially, unfortunately, prescribed only celecoxib as needed and physical therapy. So the red flags in this patient is that this is a young patient with elevated acute phase reactants, severe morning stiffness, and pain which improved with activity but not with rest. And it's important to take note of disease and of this disease entity called spondyloarthritis, which is comprised by your ankylosing spondylitis, enteropathic arthritis, psoriatic arthritis, reactive arthritis, and undifferentiated SPA. And for ankylosing spondylitis, which is the case in this patient, you will have this constitutional manifestations such as your fever, fatigue, pain in the jaw, costochondritis, chronic pain at the sacroiliac joint or in the lower back. You have your GI symptoms, pain that gets worse with inactivity or sitting still for longer periods, or pain at rest, and then the pain that gets better after a hot shower. You have your uveitis or eye redness and inflammation. Some patients can present with a rash like psoriasis or have alternating buttock pain or pain on the heel like in plantar fasciitis or Achilles tendinitis. And the diagnosis is made using the ASES criteria. So these patients will have more than 3 months of back pain occurring at less than 45 years old with sacroiliitis on imaging and one of the SPA features as mentioned a while ago. So it's important to note that there's a difference that when taking the history and physical examination of the patients, you have to differentiate between inflammatory back pain versus your mechanical back pain. And again, the main differentiating factor in the history is that the pain in inflammatory back pain improves with exercise but not with rest. Because we want to take these patients early in the course of the disease, in the non-radiographic stage or the early radiographic stage, before they proceed into full spine ankylosis, because by this time it will be very, very hard to treat them or bring them back to normal. So for this patient, diagnosis of AXPA was made based on the presence of inflammatory back pain in conjunction with enthesial pain or pain in the insertion sites of the tendons. In this case, plantar fasciitis. This patient also has peripheral lower extremity arthritis, inflammatory markers which are elevated, radiographic sacroiliitis, and a positive HLA-B27. And it's important that these patients be given NSAIDs continuously until such time that the inflammatory markers have resolved or the patient's function and joint inflammation has already resolved. These patients must also be referred early to a rheumatologist so we can initiate conventional synthetic DMARDs or even our biologic DMARDs. And the treatment for ankylosing spondylitis or spondyloarthritis consists of a partnership with other medical disciplines, such as your physical therapist, your orthopedic doctor, as this will require education, exercise, physical therapy, rehabilitation, and patient association groups. So in summary, there's no substitute for good history taking and complete PE. Sometimes you don't have enough time, but we have to take time. You have to ask for red flags and prompt patient, as they oftentimes have the inability to correlate past problems or symptoms, or in other cases, they tend to overcorrelate. Should never base diagnosis on imaging, and just because it's there, it doesn't mean it's the culprit. Always correlate. Image only when the pain is persistent or when there are red flags. And in patients with red flags, the ESR or the CRP will clue you into a more systemic problem. But just because the ESR is low or normal, it doesn't mean that there is no systemic problem. The absence of evidence is not the evidence of absence. In young males or even females with chronic low back pain, it is wise to consider early referral or workup for spondyloarthritis, especially if the presentation of back pain is inflammatory in nature. Try to avoid diagnosing them with chronic back strain. They are young. And use NSAIDs continuously rather than as needed for patients with axial spondyloarthritis. Use DMARDs for peripheral arthritis. Screen for TB and HEPA before initiating these DMARDs. And if possible, refer to a rheumatologist for possible biologic DMARDs early in the course to prevent disease progression. Let me end with these two slides. Since most of our patients or even ourselves just suffer from mechanical back pain at one point in our lives, we should always strive for wellness. So what is wellness? Wellness is taking care of all the parameters of your life. Everything's got to be in balance. If all the parts of these things are in balance, then the way our mind will process the information and recruit all these muscles and co-contract to the load of the spine are in balance, and we will minimize our load to the spine. This should be part of how we take care and educate our patients to take care of themselves day in and day out. And whatever keeps us busy during these challenging times, let us try to maintain our well-being by loving what we do, even if it causes a bit or a lot of back pain. Have a love-filled, backache-free day. Thank you for staying with us until the last lectures of the last day of the conference. Good afternoon.